Both the terms have been elaborated, both the terms have been used in the journal, mid-range or mildly reduced. Both are abbreviated by MR. So heart failure with mid-range ejection fraction, that means 41, 49, and preserved ejection fraction is more than 55. And very new is heart failure with improved ejection fraction. That should lead to some clarification. What is improved ejection fraction? Symptomatic heart failure with a baseline ejection fraction less than 40% and a 10-point increase from baseline EF. A second measurement of LVEF more than 40% in a certain time. This time has been allocated in the European Society, that is 2 to 3 months. After 2, it was like I gave an example. It was 32%, and after 2 months it is 42%. It needs to 42%, and that should be crossed 40%. This is called improved ejection fraction because its management and treatment strategy and drug strategy is different than other variety. So heart failure with improved ejection fraction. This is the same definition. This is the EHC guideline 2021. Reduced ejection fraction, mid-range ejection fraction, and improved ejection fraction. Last one is improved ejection fraction. That is 10 points should be increased from below 40 to above 40. Other lot of classification we keep in mind in etiological and pathological, like acute versus chronic, systolic versus diastolic, right versus left, high output versus low output. Just I recapitulate, not go detail. There is also other etiological and working classification in the CCU, hypertensive heart failure, pulmonary edema, cardiogenic shock, acute and chronic heart failure, high output failure, and right ventricular failure. Just I like to add one slide for pathological. All of you know the common causes, the coronary artery disease, hypertension, pulmonary, and also drug-induced or like this. And less common causes, and not less to us, I think HCM and myocarditis is not common, but long-term diabetes and postpartum is not common, but not less uncommon. And in revised classification, I have shown the definition. Right now, the correlation between the EHC and SEC guideline, the new classification. In SEC is black letter, in SEC is red letter, in black letter is the EHC. Stage 1 of SEC is EHC called it at risk of heart failure. Stage B is the pre-heart failure. Stage C in EHC in 2021 is symptomatic heart failure, is called the decompensated and compensated in SEC. And advanced, it is refractory heart failure in SEC. In EHC told it the advanced heart failure. But at a high risk is called new, and pre-heart failure is new in EHC. But it is normal in SEC, and it is pre-heart failure in symptomatic in SEC. So if we correlate normal in SEC, all normal, no symptom, no exercise stop, impairment, no normal age, it is normal. But in ECC, it is pre-heart failure. In B, it is no symptom, no exercise, it is pre-heart failure. And C is divided into compensated and decompensated. And in EHC, it is called symptomatic heart failure. And refractory heart failure is called advanced heart failure in EHC. Why it is important? It is very important very important to preserve ejection fraction. If we treat a normal heart, if we treat a normal patient, we cannot prevent, incidence of prevalence cannot be reduced. Because preserved ejection fraction and reduced ejection fraction, the mortality rate is 29 to 30, 1 year, and 5 years, 65 to 68. Preserved and reduced ejection fraction, very close. Minimal statistical significance is minimal. 1 year, no difference. 5 years is minimal. So we must take before treat, we must not miss, all our request not miss the diastolic dysfunction. That means preserved ejection fraction should be carefully measured, because it is the disease of exclusion of this stage. Heart failure with preserved ejection fraction is the disease of exclusion. So very carefully it should be denoted and addressed. Comorbidities, all of you know, this is very neglected chapter of heart failure. Heart failure is there, but we never look the patient is suffering for gout, iron deficiency, renal impairment, coronary artery disease, COPD, depression, even then sleep disturbance or cancer. Anemia is particularly should be addressed because it aggravated the symptom. How comorbidities? Thus, comorbidities may affect the treatment of heart failure. Why? It is caused the worsening of the heart failure, and one treatment of comorbidities adversely react with the treatment of the heart failure, and most comorbidities associated with worse clinical status and are predictor of poor prognosis of heart failure. Approach, how to approach the heart failure patient? I skip this slide. History, clinical examination, and complementary test, and that should be biomarker. That should be cardiac biomarker, preferably NT-proBNP, because in definition it is incorporated as a sole parameter. Approach is again important. I can recapitulate, and I can, dear learned participant, ejection fraction with preserved ejection fraction is more difficult than diagnosis of the reduced ejection fraction. Be careful with this. Very nice color Doppler echo, diastolic dysfunction assessment, LV, diameter, LV, thickness, all should be kept in mind to preserve, to categorize the preserved ejection fraction heart failure. What is biomarker? A few slides I intentionally give what much important and how large study have been going on. There is, all of you know, there is a NT-proBNP is there, even C-type natural peptide is also there. There is a lot of peptide have been released when is the chamber LV, LA, RA chamber is even then raised slightly, even then volume increase slightly. So BNP or NT-proBNP are gold standard biomarker for diagnosis and prognosis in the heart failure. At this stage, I request to the President Secretary of Cardiac Society to reduce the rate of NT-proBNP, how it is available up to the district and upazila level. This is another study, large study, that is the cardiovascular hospitalization is depend on the prognosis, and hospital discharge also depend on the NT-proBNP marker. All-cause mortality also high in the whose patient have high biomarker than less biomarker. And this is very important that the primary center also there is role of this biomarker. And this is also very important, patient population, biomarker and action. Risk factor, only patient has risk of heart failure. There also monitoring of the biomarker, slight rise of NT-proBNP, more frequent follow-up considering of the intensification of the existing therapy. Ambulatory patient, if it is 30% increase, more frequent follow-up and intensification of the treatment, and even then hospitalization patient, it meets the criteria to discharge the patient on biomarker. Pharmacotherapy, this is my target. What is the target? Reduce mortality, increase more quality of life, and prevention of the heart failure progression at least. All of you know the cardiac abnormality, whether it may be anatomical or structural or functional, central nervous system, renal endocrinal system, and epilepsy system are activated. And all of you know this is the vicious cycle. Two are the detrimental, one is the beneficial. SNS, central nervous system, we can combat by beta blocker, and RAAS is combated by the acid inhibitor, ARB and mineralopathine inhibitor, and very new is the natriuretic system, we can combat, we can fight by the secretor consulted by army. This is the beneficial effect. All the two effects are the detrimental effect. Some are short acting, some are long acting, particularly neprilysis, and RAAS are the long acting effect on the outcome and prognosis of the heart failure. This is a study, all of I think we know. This is the purple color is the 2001, and it comes the valsartan, particularly here becomes the treatment of heart failure. Blue color is the beta blocker, and evaporating is the shift dial come to the treatment in the algorithm of heart failure guideline. And the some yellow color is the study through which the device has come for the treatment of heart failure. And paradigm trial is also very old, 2014, where the ARNI has come, emerged as a third-line therapy of, at that time, third-line therapy of heart failure treatment. But what are the new treatment? After 2014, after paradigm heart failure, there is a long gap. 4 years there is no study. 2018 there is some small study happened. And there is in 2019 there is a Dhaka heart failure study is one of the important, and pioneer heart failure study for hospitalized patient or decompensated heart failure patient have been introduced as ARNI. And Dhaka is the drug which is used for the diabetic 2 patient SGLT inhibitor, which are promising. And 2020 there is the Emperor reduced trial, for which I think today's they have arranged the is very, very promising for the heart failure patient. Just 1 year back, August 28, the result is published. So these two drug, diabetic drug, with or without diabetic patient with heart failure is promising result. And also, RG is also new dimension in 2019 is used in the compensatory heart failure. The Emperor reduced trial, the result, I did not see the detail. What is the primary endpoint? Cardiovascular death reduced 25%. First, second, the hospitalization rate 30%. And glomerular infiltration rate, that means cardiac renal function is improved 50%. It is, I think it is very good drug for the heart failure patient, because most of the heart failure patient renal function is gradually deteriorated. So decline of the glomerular filtrate rate you can hold or even then stop. So the conclusion of Emperor reduced trial is 25% decrease in the risk of the composite of the cardiovascular death and heart failure hospitalization. Emperor reduced and Dhaka trial, and total number of hospital heart failure slowed the rate of the progression of the renal disease. And last one is taken together. It is the Dhaka and Emperor reduced trial, which indicate that SGLT inhibitor is a new standard of care of drug which reduces ejection fraction with or without diabetes mellitus. This is the inference of this one. And we saw what are the new, because I am asked to ask the new things about the heart failure, paradigm 2014 and pioneer heart failure trial 2019. ARNI used in the acute decompensation, and this is the chronic heart failure in 2014, and ARNI also recommended through this trial, pioneer heart failure trial. Pioneer heart failure, all of you know, I speak, the 21% reduced the hospitalization, rehospitalization, death is 20%, 38% is the readmission, and it is, all of you know, prematurely stopped, and 20% cardiovascular mortality, 21% rehospitalization reduced, then NLRP, and mortality rate is 16%. And pioneer is very new trial. All of we know when heart failure patient goes deteriorate, what happened? We use bronchodilator, vasodilator, renal furosemide, glutamine, and noradrenaline, and also sometimes BiPAP, CPAP, and also some filtration is needed. At that place also there is a study, a pioneer heart failure study, and it shows the promising result. They are comparing the NLRP, 20% reduce the composite death. And so the inference of pioneer trial is that the superiority of ARNI or other ACE inhibitor in hospitalized patient. What guidelines said? New guideline. In 2016 or 17, the ARNI was the third place. First is ACE inhibitor, ARB, beta blocker. Second is mineralocorticoid, and ARNI was the third place. But what is the new in the 2021 update to the 2020 RACE expert? What they said? They said the ARNI will be the first place. ARNI will be the first place, and considering the renal function, heart rate, and pulmonary congestion, add on the aldosterone, SGLT2 diuretics, intravenous arterial diuretic, isosulfite, and tachycardia, if there is tachycardia, with sinus rhythm, evaporating should be given. So first is ARNI, second is S inhibitor and ARB. When the ARNI is sensitive or angioedema, or in our perspective, I had when patient cannot capable or economically not viable, then S inhibitor. But without any of these things, ARNI is the first choice to treat the heart failure, then second choice, then third choice is the beta blocker. And I did not go detail. There is the parameter which is considered before start ARNI and follow up by this. So this is also another very new slide, very new information. What are the new drug? What are the new drug which have already been probably already been come out in the textbook, like Bronwal, latest edition, and also Hust. Calcitrol, increase the intracellular calcium, one of the common drug. Myotrop and mitotrop. Myotrop, myosin activator, omicarbal is commonly in the European and American market. And mitotrops reduce the cellular metabolism, reduce the production of toxic oxygen species. This is the one of the common drug. Trimetazidine is available in our country. And Canvas trial, Cannabis heart failure trial, Canafloxacin in heart failure is emerging. Dhaka already discussed 21. Emperor reviews trial 2020. Emperor already described. Pioneer 19 already I have gone, and Paramount trial, heart failure rejection function, Valsartan already used, and Paradigm style. All studies the beneficial of ARNI in all type of heart failure. Even then in preserved rejection function, though it is not still not recommended drug administration. In ARNI, the first line therapy, they also agree. In the European Society also agree. Since 2019, the ARNI will be the first line of therapy. So what the last message of mine is there is the four pillar of heart failure patient. ARNI is the first, beta blocker is the second, mineralocorticoid inhibitor is the third, and SGLT2 inhibitor is the fourth. Consider the additional therapy as add-on at the end, adding after these things, add the other therapy. So I think this is the fourth pillar: initiate, optimize, and reassess. This is the summary of the treatment of the heart failure. I think very short summary. So they are learned audience. So my take-home message is very clear. Heart failure encompasses is about versatile etiology, so difficult to prevent, and progression and treatment also difficult. Then management should be begin at stage A and B. Management should be stage A and B. It's very important. Thereby delaying the stage C. There is a number of recommended therapeutic agents that can be reduce the modify the disease course. ARNI are the preferred agent, but for patient in whom ARNI administration is not possible, the S inhibitor and ARB is recommended. Newer agent like SGLT2 inhibitor shows promising effect on the mortality and morbidity in future guideline. ICD also some role, CRT also role, but to the society, to the president and secretary, last but not least, awareness program among all sectors to give the utmost emphasis on prevention, early prevention, early detection, and management and rehabilitation program of heart failure should be extended all over the country up to district and উপজেলা level. Thank you. প্রতিরোধী প্রথম and প্রধান আপনার হৃদয় আপনার হাতে আজ থেকে হার্টের যত্ন নিন. Thank you, sir. Thank you all the audience for patience here.